Hello, my name is Sergei Bedrikovetski. I'm a member of the Royal Adelaide Hospital Colorectal Research Group, and the topic I'm presenting for you today is artificial intelligence for the diagnosis of lymph node metastasis in patients with abdominopelvic malignancy, a systematic review and meta-analysis. Lymph node staging is done by radiologists. However, there are several shortcomings of the current technique for detecting lymphadenopathy on CT and MRI scans. It's time-consuming, burdensome, somewhat inaccurate with 70% accuracy, and it's an expensive process. So our problem is perfectly tailored for artificial intelligence. Considerable strides have been made in applying artificial intelligence to medical imaging. The two most popular models being radiomics and deep learning. Radiomics consists of you segmenting the area of interest, in our case the lymph node. After segmentation, you would extract geometric features, intensity features, and textual features, and you'd input those features into your classifier. And after training, the classifier will give you an output or a diagnosis. Is the patient lymph node positive or lymph node negative? However, we are not certain that the features we are inputting into our classifier are the optimal features in order to solve our problem. Therefore, a new model called deep learning overcomes this limitation by extracting and classifying the features automatically, giving us a more powerful algorithm and a more accurate diagnosis. The aim of our review was to assess diagnostic performance of deep learning in radiomics models for the detection of lymph node metastasis in abdominopelvic malignancy. Our methodology consisted of a search of PubMed, Embase, ScienceDirect, and IE Explore over a 10-year period. Our inclusion criteria were English language studies, artificial intelligence, CT or MR imaging, lymph node detection, and abdominopelvic region. Our exclusion criteria were case reports and conference abstracts. Our initial search found 498 papers, and by using our inclusion-exclusion criteria, we ended up with 21 papers fit for qualitative synthesis and 17 papers fit for quantitative synthesis. Our final results showed only one study in rectal cancer that used the deep learning model to detect malignant lymph nodes. The study was done by Liu and colleagues, which consisted of 414 patients. The area under the ROC curve, and those that are not familiar with the area under the ROC curve, the closer the value is to 1, the more accurate the artificial intelligence algorithm is. The closer the value is to 0.5, the less accurate it is. Liu and colleagues obtained the area under the ROC curve of 0.912, and even though they had impressive results, their study had a limitation, which was they used the radiologist assessment to train the algorithm. And as I earlier mentioned, the radiologist is only correct 70% of the time. A more beneficial strategy to train the algorithm would be to use the pathologist assessment in order to train the algorithm. These are the results for 17 radiomic studies. We analyzed those and we split them into surgical specialties. We have colorectal, gynecology, hepatobiliary, upper GI, and urology. The table shows the number of studies in each surgical specialty, the number of patients, the summary estimate of the area under the curve, heterogeneity, and heterogeneity p-value. We can see from our table that urology had the algorithm with the highest performance with an AUC of 0.895. We can also see from our table that colorectal had the lowest area under the curve, so they had artificial intelligence algorithms with the lowest accuracy of 0.798 compared with any other surgical specialty. These are the results for the accuracy of the radiologist assessment for detecting lymph node metastasis. Our table was once again split per surgical specialty, and we found that urology had the highest area under the ROC curve with a value of 0.774, and hepatobiliary had the lowest area under the ROC curve with a value of 0.633. Overall, we can see that the accuracy of the radiologist assessment is around 70%. We used the QUADAS-2 tool. This tool is used to evaluate the risk of bias and applicability of primary diagnostic accuracy studies. The QUADAS-2 tool consists of 4 key domains. These are patient selection, index test. In our case, the index test is the artificial intelligence algorithm, the reference standard, and flow and time. In the domain of patient selection, we found 15 studies with a high risk of bias. Those were due to being retrospective in nature. We found 12 studies with a high risk of bias in the index test. And this was due because the artificial intelligence algorithm's results were found or interpreted with the knowledge of the reference standard. With regards to reference standard, most of the studies used the correct reference standard, which was the pathologist assessment. And with regards to flow and timing, all 21 studies included in our review were unclear if there was a timing between the interpretation of the results of the index test and the reference standard. There were almost no concerns or no major concerns regarding the applicability of our studies. In conclusion, radiomics models improve the diagnostic accuracy of lymph node staging for abdominopelvic malignancies in comparison with the radiologist assessment. Deep learning models may further improve on this, but data remain limited. I would once again like to thank the ESSO committee for giving me the opportunity to present my abstract at this conference. Thank you very much.